I want to begin by asking you please to state your name.
My name is Jim Simon.
And you are?
I'm a reproductive endocrinologist and menopause specialist in Washington, D.C.
Now, I had the pleasure of hearing you give a talk yesterday about the topic of novel approaches of estrogen, and one of the areas you spoke about was estrogen with its impact on breast cancer or not. I wonder if you could talk a little bit about that.
Yes, certainly. I think it's very well understood by lay people, or thought that they understand, that hormone therapy or estrogen therapy increases the risk of breast cancer. And that's really a deep-seated belief in our medical system and amongst patients. But it turns out not to be true. And in fact, estrogen may actually slow the growth of existing breast cancers, while estrogen and progesterone might increase the growth of existing breast cancers, but neither actually cause the breast cancer.
So how do we get it so wrong?
Well, within a given period of time, if about 10% of women have breast cancer and don't know it, and we give them a medication that increases the growth rate of that existing breast cancer, it's likely to grow to a point where it can be recognized on a routine mammogram. And so more cases would be apparent because of that growth, and the appearance of those cancers would thereby be attributed to the hormone treatment, giving the impression that the hormone treatment caused the breast cancer.
So that many of the breast cancer cases with estrogen treatment actually took place in women who already had breast cancer, and it was simply diagnosed while they were on it.
That's correct.
Now, we talked yesterday, and I heard you speak yesterday, about it matters when people take estrogen, and I wonder if you could speak to that.
Certainly. When a woman begins her estrogen or begins her estrogen and progesterone is critical to the benefit versus the risk of those therapies. And we sometimes call this the window of opportunity, or we call this the gap hypothesis or the timing hypothesis. All of these expressions are meant to mean the same thing. And what it means is that in the context of estrogen or hormone therapy, what we know to be true is that early use of estrogen or hormone therapy, when I say early, let's say by women in their 50s, is of benefit, overall benefit to those women's health in a variety of ways, which we can talk about further. Whereas if they're outside the window or late in the gap, they in fact get mostly risk for being on their estrogen or their hormone therapy.
So basically what you're saying is there's an estrogen window of opportunity, and to take advantage of it, to lower the risk of breast cancer, start your medication early, close to the time of menopause, or in your 50s anyway, for optimum benefit.
Yes, for optimum benefit. And that benefit is greatest not for breast cancer per se, but is greatest for cardiovascular disease prevention and all causes of death. You can actually reduce all causes of death by a significant margin by starting one's estrogen or estrogen and progesterone in the 50s.
Thank you very much.
Thank you.